Hello, everyone. And today we are going to be talking about psychotic disorders and catatonia. This is for the Psychiatric Mental Health Nurse Practitioner exam. So psychotic disorders are some of the most debilitating psychiatric conditions. And when we say that somebody is psychotic, what that means is that they're having hallucinations, delusions, disorganized speech or thinking patterns, referential thinking, so thinking that things outside of them are referring to them, whether it's something on TV or a YouTube channel or something on the radio, abnormal motor movements, and negative symptoms. So when we talk about hallucinations, these are false sensory experiences without stimuli. It can really affect any of our senses. So there are auditory hallucinations, so hearing things that aren't there. That is the most common, but people can also have visual hallucinations. A lot of times people will say they see like shadow figures or they see disturbing things. Tactile hallucinations, this is feeling like things are on your skin. So maybe like they might feel like bugs are crawling on their skin. That's kind of a more common one, I guess. Olfactory, so smelling things that aren't there. And gustatory, not sure exactly how you say that, but that's tasting things that aren't there. Hypnagogic or hypnophic, again, another word I don't know how to say. So this is really the state before falling asleep or right when you are waking up from sleep. Experiencing hallucinations at that time is actually considered normal, and they're not hallucinations. It's because your body is still in like a wake sleep state, like that in between. Sometimes people might say, they woke up from a dream and they saw a person standing in the room, and then when they sat up, that person was gone. That delusions, these are false beliefs, firmly maintained. So you cannot reason with a delusion. A person believes a delusion to their core, despite there being any evidence of it. There are different types of delusions. So persecutory, so believing that others are out to get you, religious delusions, grandiose delusions, jealous delusions, somatic delusions, so a false belief that a person's bodily functions are abnormal. There are certain conditions, for example, something like Cotard's, where people feel like they're missing a limb, but like the limb is there, but they swear to God that it's not there. Also part of Cotard's, they can believe that they're dead and they're not, right? They're clearly living, but they believe to their core that they are dead. So those are kind of those somatic delusions. Erotomaniac delusions, or I don't know how you say this, but that is another name for it, is a rare paranoid condition that causes people to believe that someone, usually of higher status, is in love with them. Sometimes we can see this with celebrities where people will like stalk them and feel like they're in a relationship with them and all of these things, but they are not. So that is another type of delusion. So disorganized thinking, when we talk about this, it's problems with informal organization and interpretation that is best assessed in speech patterns. So we can tell that somebody is disorganized typically by the way they are talking, but sometimes we can see it with their actions as well. So different types. So a bizarre delusion. So they might say something like, I was captured by aliens. That's a delusion. Some people might believe in aliens, but most of the time it's a delusion. Tangentiality. So their thoughts are connected, but they don't go back to the point they were talking about. They just kind of like go on and on and on. And I think I have another slide in here somewhere. I think it's in the mental status exam that explains this a little bit better. But like if something was tangential, right? I could be like, we could be talking about breakfast, right? And then next thing you know, I'm talking about oranges. And then I'm talking about Florida. And then I'm talking about the Miami Dolphins, right? So technically they're all connected, but because like oranges come from Florida. Florida is where the Miami Dolphins are. So like they're connected, but they're not really answering the question or involved in the same conversation that originally started as breakfast. So that's kind of like a tangential thought. It just keeps going on. Loose associations, answers that have no connections, illogical answers to questions, just not really making sense. There might be some subtle connections like we talked about with the like Florida, Miami Dolphins, all that stuff. But they're loosely associated. They're not really answering the question. Word salad, these are incomprehensible mixture of words. Pretty much it sounds like the patient is making up their own language. The words are just all combined and it just doesn't make sense. Thought blocking. So this could be an abrupt halt of talking where they just stop, right? They can't get their full thought out. Or it could be like you're trying to talk to them about something and they're just blocked, like they're not engaging in that conversation, or they're not able to like see that point of view or have a thought about it. They might just be like, no. And there's no real like back and forth. They're just like blocked. And then echolalia, I like to think of this as like, it says echo in the name. So I like to think of it as like an echo. And sometimes you'll see this with patients, and we're going to talk about this later, but sometimes with catatonia, you can see this, where the patient will either repeat the same word that they said, or they'll repeat a word that you say. So like you could be talking to them and be like, how are you feeling today? And they're like, today. They're just repeating it. Disorganized behaviors are usually unusual behaviors that range from childlike silliness to anger. It can really be across a whole spectrum of emotions. It's just a disorganized component to it. So there's silliness, anger. These people are going to have difficulty with their activities of daily living. They're typically going to be disheveled, not showering for days, odd or unusual clothing, inappropriate sexual behaviors, and stereotypic motor activities. So kind of doing the same type of things over and over again. Sometimes we can see people, you see a lot with disorganized behaviors, like patients, they might do laps around the unit, right? Or they might always do like the same route. Like maybe they go from one milieu to the dining room to the other milieu, and that's like kind of their pattern. They're just kind of doing the same thing over and over again because they're disorganized. Referential thinking and delusions of control. So beliefs that events, actions, or situations in the environment hold a special significant meaning. So there's different types. So thought insertion is believing that somebody else is putting thoughts into your head. Thought withdrawal is thinking that others are stealing your thoughts. So for example, like the CIA is stealing my thoughts. That would be a thought withdrawal. Thought control is believing that others are controlling your thoughts. And then thought broadcasting is feeling like your thoughts are being broadcasted out to the world. And these are all different types of delusions of control because it's like someone else or something else is controlling you. All right. So psychosis. This is when you're going to see on some of these slides a picture of movies. If you guys like movies, these are movies that I recommend that kind of show you what the diagnosis is. So it can be kind of fun in learning these diagnoses. I don't want to give the movies away too much. So for psychosis, we have this movie Bliss. I don't want to give too much away. I feel like this movie didn't get enough hype. I thought it was really, really good. So it's on Amazon Prime. Highly recommend. So with psychosis, this is when people are out of touch with reality. They have that disorganized thinking we talked about. They have possible hallucinations, possible delusions, bizarre behaviors and mannerisms, fears. Oftentimes they're paranoid. So to assess that, typically we ask people, do you feel like anyone's following you? Do you feel like anyone's talking about you? Do you feel like anyone's watching you? And kind of getting information about that. And then mood changes. They can have speech that can be odd or not make sense, and they can have sensory overload or be withdrawn, isolate, or act out. Medical causes of psychosis. So psychosis can be caused by a number of different things, right? You can have psychosis because you have, let's just say you have bipolar disorder, right? Sometimes when you're manic, you can appear psychotic. You could have schizophrenia and appear psychotic. You could abuse substances that make you psychotic. You could have a medical condition, like we're going to talk about here, that makes you psychotic. For example, I'm sure it's listed on the slide somewhere, but like some people have autoimmune diseases where the body actually attacks the brain, and it's called autoimmune encephalitis is what happens. If you've ever seen Brain on Fire, that is what the movie is about. And all of these diseases are very sad, but it's a very sad disease because you see people who are, functioning in the world and all of these things, and they have an autoimmune flare up and they're completely psychotic. So it's it's very interesting. But here are some other diseases that can make, or medical conditions that can make people psychotic. So neurodegenerative disorders, so Huntington's disease, multiple sclerosis, and Alzheimer's disease. Again, not all people who have these diseases will get psychotic, but it just depends the way the disease progresses, right? Some people can. Central nervous system disorders, temporal lobe epilepsy, head trauma, neoplasm, vascular diseases, so there's a list of them there. Infectious diseases, so AIDS, herpes, Creutzfeldt-Jakob disease, that is another very sad disease. Neurosyphilis, uremia, hypercalcemia, hyponatremia, hypoglycemia, Addison's disease, Cushing's, vitamin deficiencies of B12, thiamine, or folate, different medications like corticosteroids, anabolic steroids, different antibiotics. There's like a bunch there. I'm not going to read them all. Different substances. Again, there's a bunch there. I'm not going to read them all. Different toxins. Then there are visual hallucinations that are not related to psychiatric diseases. Like a lot of times when people have visual hallucinations, like we talked about, audio hallucinations are pretty common, but visual hallucinations aren't as common. So when people are having these, we always want to make sure there's a medical rule out. So here are just some examples of other disorders that might report visual hallucinations, but actually it's a medical condition. So it could be problems with the eyes, vision loss, migraines, seizures, or neurodegenerative diseases such as Parkinson's, Lewy body disease, etc. So when we talk about we're going to talk about schizophrenia. And when we talk about the symptoms of schizophrenia, to get the actual diagnosis of schizophrenia, those symptoms need to be present for at least 6 months. If they are not present for 6 months, there are other disorders that it is classified as. So if it's between 1 month and 6 months, it's called schizophreniform disorder. And if it's 1 day to 1 month, it's called a brief psychotic disorder. So when we talk about schizophrenia, or that schizophreniform or brief psychotic disorder, again, depending on the timeline, what we're looking at are 2 buckets of symptoms. So one is the positive symptoms and one is the negative symptoms. To have a diagnosis of, and I'm just going to say schizophrenia, but we know if the timeline is shorter, those other 2 diagnoses apply. To get a diagnosis of schizophrenia, you need both of these symptoms. So you can't just have hallucinations and delusions and be schizophrenic. Like, that's not how it works. You have to also have the negative symptoms of the disorder, because as we talked about earlier, hallucinations and delusions, which encompass like psychosis, right, can come from multiple different places, right? The medical ones, it could be a mood disorder like a bipolar, or even major depressive disorder can have psychotic symptoms at times. So again, it's not just the hallucinations and the delusions that classify schizophrenia. You need the positive and negative. So those positive symptoms are hallucinations and delusion, but the negative symptoms are going to be minimal emotional expression. This is called a flat affect. Sometimes people also use the word blunt affect. And what that means is there is less emotional expression. So for example, this is me normally talking, right? If I was going to have a flattened affect, it would be like this. The tone of my voice would be pretty not moving. My facial expressions would be not as excited. Okay, that's all I can do. That's a blunt or flattened affect. Odd speech, bizarre behaviors and movements, and impaired social functioning or difficulty relating to others. For example, they might have poor eye contact when you talk to them. It's just an example, but there can be a lot of different things. So like we talked about, there are going to be some examples of movies. Both of these movies are classics. I'm pretty sure they're both on the like IMDb top 100 or 200 movies. I know A Beautiful Mind, I think, is like number 3. So it's a really good movie. And the thing that is nice about these movies is both of them are true stories, which is amazing. So A Beautiful Mind, a lot of you guys have probably seen this, but just because it's on the slide, so I don't want to give it away too much. But this man is a brilliant mathematician who developed schizophrenia in his life. And it's kind of like his journey, but he is very smart, and it's a really good movie. And then this other movie is The Soloist. It is about a homeless man who is a pianist, and it's really good. It's a true story. So another good one you guys can watch if you want to kind of see these disorders kind of in real life, I guess. All right. And so when we talk about schizophrenia, it causes significant disturbances in many areas of the brain, which impedes different functioning. So it causes problems with cognition, perception, emotion, behavioral, eye movements, and socialization. So there are different pathways in the brain that they have found are associated with these different symptoms of schizophrenia. So these are important to know for the exam. We're going to go over other points of these different discussions that we have talking about the brain pathways and the signs and symptoms. So you're going to see this more and you're going to see it again. So don't worry too much about it at this moment. But the positive symptoms of schizophrenia are associated with the mesolimbic pathway. The negative symptoms of schizophrenia are linked to the mesocortical or prefrontal cortex. Cognitive symptoms are associated with the dorsolateral cortex. The aggressive symptoms come down to the orbital frontal cortex and the amygdala, and the affective symptoms are the ventromedial and prefrontal cortex. And then the negative symptoms are also associated with the nucleus accumbens, which is where our reward circuits are. So the prefrontal cortex in this area is where the mesocortical and ventromedial, sorry, that spelled wrong, but medial is located. This is where the negative and affective symptoms come from. The dorsolateral is cognition, orbitofrontal is aggression. So dopamine is synthesized from the amino acid tyrosine, and tyrosine converted into dopamine by the enzyme tyrosine hydrolase, and then by the enzyme dopa-debocarlase. So this is kind of goes into how the medications work, but these are just, don't get too caught up in these. We're going to go over what you really need to know with the pathways in a different portion. So where does schizophrenia kind of come from? So there are multiple theories that range from psychological to neurobiological. It probably comes from a multifactorial thing. So the neurobiological theory implicates that there are three areas of neurobiological functioning. So genetics, neurodevelopment, and neurobiological defects. Genetics, so and this is all under that neurobiological theory. So when it comes to genetics, there have been studies of twins that identify that schizophrenia has a strong genetic component. There is a polygenetic SNP deficit believed to exist. No specific gene has been identified, but some people believe that chromosome 6p2422 has been implicated. Neurodevelopmentally, genetic defects are believed to cause abnormal neuronal cell development, connections, and organization and migration through inadequate synapse formation, causing excessive pruning of synapses and excitotoxic death of neurons. So that is important to know. We want to know that schizophrenia, when it comes to the neurobiological theory and neurodevelopment, one of the things that is thought is that there is an excessive pruning of synapses. That is important. Remember that you may see that. Intrauterine threats may contribute. So oxygen deprivation, exposure to toxins, malnutrition, or substance use. So there have been abnormal brain structures identified in people with schizophrenia. You can kind of see some pictures over on the screen that kind of show the difference between a non-schizophrenic brain and a schizophrenic brain. So what you're going to see is that people with schizophrenia have enlarged ventricles, smaller frontal or temporal lobes with reduced symmetry in the frontal, temporal, and occipital lobes, cortical atrophy, decreased cerebral blood flow, and hippocampal and amygdala reduction. So that is important. We want to remember that there is amygdala reduction and hippocampal reduction, decreased cerebral blood flow, cortical atrophy, enlarged ventricles, and smaller frontal temporal lobes. And then abnormalities lead to suspected impairment in neuronal communications. This is also important, knowing where there is more and less dopamine in the brain related to schizophrenia. So we have too much dopamine in the mesolimbic pathway, and we have too little dopamine in the mesocortical pathway. There is excessive glutamate, but decreases in GABA and serotonin. So incidence and demographics. So one thing I just want to talk about really quickly when it comes to the neurobiological theory, this idea of genetics related to schizophrenia. There is a book, I'm trying to think of the name of it. I think it's called Hidden Valley Road. And it's about, I'm going to get this slightly wrong, but it is about like 12 siblings where 10 of them, who are the boys, have schizophrenia. So it really was one of the first families to show that there is a genetic component, and just very interesting. They actually just came out with a documentary version. I probably got the number of siblings wrong. It might be 12 siblings and 8 of the boys have schizophrenia, but it was one of the first families that showed that there was a genetic component. So just really interesting. You could look it up. All right, so incidence and demographics. So it occurs more often in men, and it typically happens around the ages of 18 to 25. Men tend to have more negative symptoms and poorer prognosis, more hospitalizations, and less responsiveness to medications than women. For women, the typical onset is 25 to 35. They usually have less premorbid dysfunction and dysphoria than men. However, they typically have more paranoid delusions and more hallucinations than men. Risk factors include a relative with schizophrenia, prenatal malnutrition or exposure to a virus or complications, or central nervous system infection in early childhood. So with schizophrenia, there is something called a prodromal period. This is early recognition of the disease. It is typically a period of time that occurs before the diagnosis of schizophrenia, where people report that they have like seen that person be odd, or like typically the person might report some different behaviors in the time before diagnoses, but like not enough for a full diagnosis. And we call this a prodromal period. So it usually happens before the illness, and they have odd or unusual beliefs, but that are not really to the delusional point. Like they just have some odd and unusual beliefs, but they're not like fully delusional. They feel unliked or picked on, but not to like a delusional component. Odd speech patterns, but not illogical. So again, it's like not enough for a diagnosis, but like something weird's going on. They can have odd speech patterns, such as digressions, where temporarily they shift from subject to subject. They might also be a little tangential, might be overly concrete or abstract. Odd behaviors, but not disorganized. Maybe they collect a lot of odd things. Maybe they're mumbling to themselves. Maybe they isolate and avoid interactions with others. So I also have this table because I feel like it is a nice outline. So some of the symptoms that we may see are unusual thought content, suspiciousness, grandiosity, perceptual abnormalities, conceptual disorganizations, which those all correspond to like what would later become the positive symptoms, and then kind of like the negative symptoms: social isolation or withdrawn, avolition, decreased expression of emotion, decreased idea richness, deterioration in their role. And then some of the basic things we might see is like changes in their emotional responsiveness, inability to divide attention, slow thinking, decreased ability to discriminate between ideas, perceptions, fantasy, and true memories, derealization, unstable ideas of reference, and visual, acoustic, and body perception disturbances. All right. So history. So things we want to find out from the patient, because there is kind of like a typical pattern of how these things progress. So we kind of talked about that prodromal period. So typically, like when you meet with people, you talk to their families or them, they're going to tell you they were a normal kid. They did great in school. They got into college. And then when they turned 21, or, they started acting strange. We started noticing that, they were isolating to their room more. They weren't interested in things they used to be, and instead were interested in, let's just say aliens or something, right? They were sneaking out of the house late and sitting out in the front yard for a few hours, but when asked about it, just said that they wanted to look up at the stars. So again, not enough to be a full delusion, but something is odd, something is strange, right? So, so that's kind of going from the progression, right? So we get to the prodromal, and then you go 6 months later and, they're having full hallucinations, no emotional responsiveness, and, they have a diagnosis of schizophrenia. So, but some of the other things that we may see in their timeline of life is, interpersonal relationship difficulties. 60 to 70% don't marry. These might be getting better now, because I do think with the internet, it makes it easier for people to meet people, and also people that might be similar and more accepting of these things. But historically, there's been 60 to 70% chance that they don't marry. A downdrift functionality over time, so lower academic achievements than their siblings, difficulty with employment, underemployed relative to their IQ. So when we look at other people of that same IQ, they are less likely to be employed. Self-care deficits, poor hygiene. They will have a better prognosis if they married. And if they have a good support system. Later age of onset typically means a better prognosis, absent of brain abnormalities, and high level of premorbid functioning. However, with the wonderful, and I know it gets a bad rep, but with the wonderful addition of antipsychotic meds into our toolbox, there are many people who can live normal lives. All right, so when we talk about the DSM-5 criteria, I'm sure you all know the DSM. If you open it up, this is what it says that you need for schizophrenia diagnosis. So 2 or more of these 5 things has to be present for a significant portion of time during a 1-month period. At least one of these must be a delusion, a hallucination, or disorganized speech. And these are all things we just talked about. And then there's some more diagnostic criteria. I'm not going to read through them all, but again, it comes down to, it's also talking about that timeline that we talked about. So for schizophrenia diagnosis, it's over that 6-month mark. If it's not 6 months, we know those diagnoses are going to be the schizophrenia form or brief psychotic disorder. There has to be a portion of time since the onset of the disturbance, level of functioning in more areas of their life are impacted. So we have to rule out schizoaffective disorder and depressive or bipolar disorder with psychotic features. Those are kind of the rule outs for this, because we're going to see similar symptoms, right? So someone with schizoaffective disorder, we're going to talk about that more when we get to that, but it really is sort of a mix of schizophrenia and bipolar disorder. So you're getting those mania and depressive kind of episodes. And then we talked about, you can have depression with psychotic features. You can have bipolar with psychotic features. And that's why a history is so important to obtain, because that's going to really help us to filter out what the true diagnosis is. It's not caused by a substance use or medical condition. And it is not, we have to look at the history. So if there is an autistic disorder or a communication of childhood, the additional diagnosis of schizophrenia is only made if there's a prominent delusion or hallucination, and has been present for at least 1 month. So just some more kind of details based on their history. All right, so we talked about positive symptoms already. Okay, but just to reiterate again, positive symptoms are caused by an increase of dopamine in the mesolimbic pathway. You will need to know that, okay? And these are an example of all the types of positive symptoms that we already talked about. And then negative symptoms, this is going to be caused, I remember all the things that negative symptoms are, a flattened affect, a poverty of speech or algoria, avulsion, which is the lack of motivation, apathy, which is the lack of interest, abstract thinking, anhedonia, where they don't feel pleasure, and attentional deficits. And these are caused by, you need to know this, a decrease of dopamine in the mesocortical pathway. So associative symptoms, so symptoms not required to be present for a diagnosis, but is often seen. So inappropriate affect, dysphoric mood, depersonalization, derealization, and high anxiety. So physical findings, things that we might see in these individuals. So abnormal eye movements, including slow tracing movements or rapid movements, poor hand-eye coordination. They might be clumsy. They might have non-localized soft signs, so loss of the ability to identify objects by touch. It's called asteronosis. I'm not sure how you say it. We might see twitches, tics, or rapid eye movements, impaired fine motor skills, dysdiadochokinesia. I don't know how you say this, which is the impairment of the ability to perform rapidly alternating movements, confusion of left versus right, and they might be mirroring. And then hard signs are decreased reflexes and weakness. We might see other signs, including malformation of their ears, narrowing or wide eyes, and highly arched palate. Mental status will reflect the signs of schizophrenia mentioned previously. Diagnostically, so we talked about this. If we do image the brain, there are some abnormalities we might see, such as enlargement of ventricles, of lateral ventricles, widening of cortical sulci, diffused or decreased volume of white and gray matter, and decreased volume of the temporal lobe, hippocampus, amygdala, and thalamus. And if we look at functional studies, we'll see hypofrontal or decreased blood flow to the prefrontal cortex, decreased cerebral blood flow and metabolism, and diffuse hypometabolic action in the cortico-subcortical circuitry. Pharmacological management. So we use antipsychotics, right? Antipsychotics treat psychosis if it's from an underlying psychiatric condition, right? Not like a medical condition or because they're taking a medication that is causing them to be psychotic, right? So antipsychotics are first line. We may use adjunct medications like antidepressants, anxiolytics, and anticonvulsants, but antipsychotics truly are the first line treatment. So antipsychotics for psychosis, we talk more in the psychopharm lecture, but I also wanted to put them in here. So let's talk about them some more. So antipsychotics come with a black box warning that elderly patients with dementia-related psychosis treated with antipsychotics are at an increased risk of death. We still use them as a risk-benefit analysis, but it's important to know. So we have our first generation, our second generation, and our third generation. So our first generation, these are our typicals. They mostly affect dopamine. And because they most likely affect dopamine, we are going to see the most common side effects being motor disorders. So those dystonias, which can be like the neck gets turned to the side and they can't unturn it. And sometimes they get an ocular dystonia where they look up and they can't not do that. Akathisia, so feeling very restless, like they can't get out of their body, they can't sit still. Pseudo-Parkinsonianism, so looks a lot like Parkinson's. We're essentially causing Parkinson's with antipsychotic medications because we're blocking dopamine in a certain part of the brain, which is actually the cause of Parkinson's, is too little dopamine. So we can see shuffling of the gait, pin rolling of the fingers, and tardive dyskinesia. This is abnormal movements of the mouth. And so those are like, we see those most common with the first generation. Second generation are atypicals. They affect both dopamine and serotonin, so they're good at treating the positive and negative symptoms of schizophrenia. These mostly have metabolic side effects, so increase in insulin level, increase in blood sugars due to insulin resistance, high blood pressure, low HDL cholesterol, high triglyceride levels, and weight gain. And then our third generation, these are atypicals, but they only have partial D2 antagonism, where our first and second generations have full D2 antagonism, meaning they block it, right? Because antagonizing is blocking. These are our RIPs, so aripiprazole, brexpiprazole, our RIPs, our caripiprazole, and our RONs, lumateperone, which is Caplyta. And these have less extrapyramidal side effects and metabolic effects. So antipsychotics, they inhibit dopamine. So we're going to see a reduction in psychosis, which is what we want. However, we're also going to see a loss of drive. We're going to see features of Parkinson's disease, loss of attention, extrapyramidal side effects, hyperprolactinemia, which causes enlarged breasts in males, and neuroleptic malignant syndrome, which is life-threatening. So our first generation typical antipsychotics, there are high potency, which have a greater risk of extrapyramidal side effects but are less sedating, and then low potency, which are more sedating and anticholinergic side effects but less extrapyramidal side effects. This is important to note. Caffeine and nicotine cause diminished antipsychotic effects, and the doses have to be adjusted. We talk about this more in our inducers and inhibitors section, but essentially caffeine and nicotine, if a patient is smoking or drinking a lot of caffeine, they are going to need higher levels of their antipsychotic because it essentially is an enzyme inhibitor. Yes, it's an enzyme inhibitor, and the enzyme breaks down the antipsychotic essentially. And so if we're inhibiting the enzyme, it's an enzyme inducer. I know what it is in my head. I had to get it right. So, okay, it's an enzyme inducer. Yes, it's an enzyme inducer. So if you're smoking and taking caffeine, then it is making more, it's letting the enzyme not break down more, so it's making lower levels of the medication in your body, so you're going to need higher levels. If a patient was smoking and you put them on an antipsychotic and it was working really well for a long time, and then they stopped smoking, you actually might be able to lower the dose because now they're going to have higher doses in their body. All right. Or you might see more side effects. All right. So the first one we have is Thorazine. And Thorazine is a low potency, and side effects include memory impairment, hypotension, sedation, and those neurological side effects. It can have a prolonged QTC interval, which we're going to talk about in a little bit. Then we have Haldol. This is a high potency. It's much more sedating at the much more selective at the D2 receptor than other first generation typical antipsychotics. It has less anticholinergic, antihistamine, and antiadrenergic effects. Because it affects D2 receptors so strongly, it has a high rate of extrapyramidal side effects, which causes that akathisia and acute dystonias, and it can prolong the QTC, especially at higher doses or if given intravenously. And we often use it when a patient is acutely psychotic or during restraint, and we typically give it with Benadryl to treat those extrapyramidal side effects. All right, so we're not going into antipsychotics as much as we did in the psychopharm lecture, but I want to just give a little overview. So first generation typical antipsychotics, here is a list of all of them here. You can take a screenshot, print it out, a lot of good information there related to the side effects, things to know about it, what the doses are. So yes. These are our second generation. So again, very similar. We have the names. So for example, clozapine, the common side effects. So tachycardia, drowsiness, dizziness, agranulocytosis, myocarditis. I will say, so with clozapine, you can't use as a first-line treatment. This is because it can cause agranulocytosis at a high enough rate that the government has kind of said, this shouldn't be used first line. If patients are going to use this, they have to fail 2 other antipsychotics first. When a patient is started on this, they have to be registered into the clozapine REMS program. It's an online program that you as a provider register them in, or you look them up and then say, like, I'm their provider. And depending on when it was started, so if you're initiating the treatment, you have to put in the patient's ANC every week. For the first, I believe it's 6 months. And then after that, I think it's every 2 weeks. And then after the year, I think it's every few months or something. So it depends the timeline, but it is highly monitored because of this. So things that you have to do, you're taking an ANC and white blood cell count every week. You're doing an EKG, checking their QTC. You're looking at their troponins, CRP, because you're looking for that myocarditis. And so there's a lot kind of to clozapine, but it is a really good medication. So just some information there. If the ANC drops below 500, then you have to stop giving them the drug. They can't take it. There's some other guidelines on the website. I believe it's like if it goes below 1,000, you have to like do a risk benefit analysis. So just interesting. Quetiapine. So this says it's sedating, hypotension, kind of like those weight gain. Some people can have elevated liver tests. We want to, you can give it BID or TID. You can even give it once a day. I'm not quite sure why it says BID, but some people get it once a day before bed. We want to monitor their weight, BMI, waist circumference, serum lipids, and glucose, because you are going to get those metabolic side effects. And then also there is olanzapine. This one's probably going to cause the most weight gain, but it is a really great medication minus the weight gain. It works well for people. Risperidone has less weight gain than clozapine or olanzapine, but it does have the greatest prolactin elevation. And then ziprasidone, this one probably has the least weight gain of the second generation antipsychotics. And we want to make sure that patients are taking it with food, as it helps it to absorb better. So yes, those are those. And then we have some more second generation, and then also kind of the third generation, which are those partial antagonism of the D2 receptor. So for our second generations, we have paliperidone, and this one also comes in in a long-acting injectable. This is like an extended release Risperdal. Some of these you may honestly not see often. Another one you're going to see is lorazepam or Latuda. This one also needs to be taken with food. And then our third generations are the Abilify, Rexulti, and Vraylar. And then also Caplyta. I was like, where's the Caplyta? Yes, so those are your third generation ones. All right. So when we talk about side effects, I just really liked these two charts. Sometimes people are like, how do you decide which one to use? And it's really, you got to look at, what are the side effects? What are the things the patient is willing to have and not willing to have? I will say in my setting, it's a little more acute. So there is a risk benefit analysis as far as it depends on the person, right? If it's a very acute situation, you're going to use what works. And obviously, you want the patient to agree to that. There's ways around it if you can't, but it's, you want the patient to agree to it, but you're a little less focused on the side effects, right? I'm sure Geodone is great, but Geodone is probably not the best thing to use when somebody is super psychotic, right? So, it's risk benefit analysis. So, but with people that are maybe not so acute, and there is kind of choices to be made, right? And this is kind of a nice chart to look at. So, for example, I think a big thing is weight gain. A lot of people are very resistant to start these meds because of weight gain. So, if we can say to people I know I just used Geodone as an example, but if it's not a super acute situation and people are like, I don't want to gain weight, well, maybe we offer them Geodone, right? It's going to be less weight gain, or Latuda or something like that. And so you can see over here as well. Or sometimes I've in the past had people who are very nervous about TD. So this is a nice chart that you can always whip out and be like, okay, that is totally understandable. Let's look what would maybe be something that is less likely to cause extrapyramidal side effects or TD. Well, maybe olanzapine, or maybe aripiprazole. So these charts can be really nice. I have a chart like this, especially for SSRIs, because there really are a lot of options, right? If people come in with anxiety or depression, there's really a lot of options. Like when do you use, Zoloft over Prozac or whatever. So that's what I like these for. So I just wanted to throw that in there. All right. So when we have extrapyramidal side effects, these are our treatment options. So Cogentin and Benadryl or Simitril, but usually we use Cogentin or Benadryl. This chart shows you some more specifically. So these ones are extrapyramidal side effects, but this chart shows you different side effects beyond that. So for example, akathisia, you could give Cogentin. However, what we usually use is propranolol, and that works really well. So you can see that down here. You could also use Ativan, Klonopin, Clonidine. That's all going to help with the akathisia. So these are all, it's a nice chart for side effects and what you can give. So when we talk about neuromalignant syndrome, and again, we talk about this in the psychopharm lecture, but this is where we are looking for these. This is like a major side effect of antipsychotics that doesn't happen often, but it is life-threatening. So we need to know about it, and we need to be able to identify it if it does happen. So we're going to see things like confusion, agitation, hypotension. Kind of the big one you probably remember even from undergrad nursing school is hypothermia. They are hot. However, this doesn't happen all the time. It's very rare. Like, it's already a rare thing to happen, and it's even rarer for them to not have a fever, but it has happened. So just note, if they have all of these signs and symptoms, but they don't have the fever, don't be like, well, it's not NMS. Like it could be. They have muscular lead pipe rigidity, so they have stiff joints, and they can have seizures, diaphoresis, tachypnea. We know they're going to have that recent antipsychotic use, elevated CPK, white blood cells, and LFTs. They may need Tylenol or a cooling blanket if they are having that hyperthermia, and they may need benzos if they're catatonic. And when we talk about catatonia, we'll talk more about that, but we'll talk more about it when we get to catatonia. So the treatment is dantrolene or bromocriptopine. All right, so let's talk about the dopamine pathways. So the first one is the mesocortical pathway, and this blocks dopamine in this pathway, causing a decrease in negative symptoms. So antipsychotics. When they go into the brain, they're blocking dopamine in the mesocortical pathway, leading to a decrease in negative symptoms. The nigrostriatal pathway, so dopamine has a reciprocal relationship with acetylcholine, whereas when serotonin is blocked by, so we know that serotonin is going to be blocked by our second generation antipsychotics. So when serotonin is blocked by second generation antipsychotics, dopamine increases, and therefore acetylcholine decreases, which causes extrapyramidal side effects. So the big thing to remember for the test, like, there's a lot of words here. So let's just go back, because this is something that you have to know. So the mesocortical pathway, when antipsychotics come in, right? So pretty much what you need to know is that the mesocortical pathway is the pathway that is involved with the negative symptoms of schizophrenia, and that antipsychotics work by blocking dopamine in this pathway, therefore getting rid of the negative symptoms. So you should know that in the mesocortical pathway, this is where the negative symptoms are, and that antipsychotics block dopamine in this pathway to reduce those negative symptoms. Then you should know that in the nigrostriatal pathway, this is the pathway that is linked to extrapyramidal side effects. And I always remember this, and I think I said this in a different discussion that we've done related to the psychiatric mental health nurse practitioner course thing we're putting together here, that I remember nigrostriatal because to me, it sounds like a dance move. It's like, do the nigrostriatal. I don't know. To me, it sounds like a dance move. So I remember this is that it's linked to extrapyramidal side effects because the stiffness and things, it's kind of like a dance move. So just know that that's what you need to, you don't need to necessarily remember that dopamine has a reciprocal relationship with acetylcholine. And when serotonin is blocked, it increases dopamine, and then that increases acetylcholine. Just know that the nigrostriatal pathway is linked to EPS and that there is acetylcholine decreases in this pathway and therefore causes EPS when antipsychotics are given. All right, so abnormal involuntary movements. So those at risk are females, older age, and long-term treatment with antipsychotics. People on antipsychotics should get what's called an Ames assessment every 6 months, and that is an abnormal movement assessment or abnormal involuntary movement. So this is what the Ames assessment looks like over on this slide. And you can see the questions. So we're looking at facial expressions or the muscles in their face with the facial expressions, their lips and area around their mouth. Are they moving? Are they smacking their jaw? Are they biting and clenching and opening? Like those are all those TD signs. We're looking at their extremity movements, lower extremities, their neck, and then overall global judgment. It takes about 10 minutes to complete. And there are 12 items and they are ranked on a 5-point scale. 1 to 4 assesses for oral facial movements, 5 to 7 assesses for extremities and trunk movements, and 8 to 10 assesses global severity. And then items 11 and 12 are a yes or no. And that will help to identify if there are any of these abnormal movements. So non-pharmacological treatments, we have individual therapy, group therapy, proactive crisis management, so signs of relapse, symptom triggers, self-care, assertive community treatment. That is a big one. You should know that. That might be on the test because really like things like individual therapy, group therapy, right? Those are the answers for most conditions, right? If you're depressed, individual therapy. If you're anxious, individual therapy, group therapy, you know what I mean? So, but the big thing for psychosis, schizophrenia is the assertive community treatment. That is like specific for it. So you may get a question about that. And what that is it's a treatment team or case management team. Illness management programs, education, milieu therapy, client and family education. So comorbidities and risk factors. So 20 to 40% of people with these conditions will also have substance use. 80 to 90% of these people who have this condition, schizophrenia, will also smoke cigarettes. And we kind of talked about that. So let's talk more about that because here it is written out nicely. So smoking induces the CYP450 pathway and reduces the antipsychotic efficacy because it's lowering the dose. So you will probably need to increase the dose for people who smoke cigarettes. If the person quits or reduces smoking, you may need to reduce the dose. Schizophrenia, it's also common to have with panic disorder and OCD. 10% of these individuals unalive themselves, and 20 to 40% attempt. And risk factors for this are males under 45 who are homeless, unemployed, non-compliant with meds, recently hospitalized, post-psychosis, or involved with substance use. Medical illnesses, so a high rate of metabolic syndrome. Obviously, that is a side effect of the medication, diabetes, hypertension, hyperlipidemia, respiratory illness, and cardiac disease. We need to provide weight management and nutritional assistance. And these are just a reminder of what the BMI categories are. Older adults, so if people have their first kind of episode older, they usually have a better prognosis. It's more common in women with rare late onset. Black box warning for antipsychotics. We talked about that. It's kind of dangerous for people with dementia-related psychosis. Risk factors, so postmenopausal, present of human leukocyte antigen and family history. Mostly positive symptoms, but meaning there's less negative, but high levels of persecutory delusions and hallucinations, low levels of disorganization, perseveration on social and occupational interests. And then follow-up. So people with these conditions are going to require lifelong treatment. We want to make sure to monitor labs for compliance of treatment and also LFTs, weight, BMI, glucose, BUN, creatinine, CBC, and an annual eye exam. So we talked about this briefly at the beginning, but let's just cover it. So brief psychotic disorder is characteristics very similar to schizophrenia, but the onset of symptoms lasts at least a day, but less than a month. Risk factors are family history. It's usually seen in adolescence or early adulthood. Management is similar to schizophrenia, and acute episodes required frequent monitoring due to confusion, rapidly changing emotions, impaired judgment, and inability to meet nutrition and hygiene needs. And then schizophreniform, so again, looking at the timeline, this is going to be at least 1 month of symptoms, but not more than 6 months. It does not require impaired social and occupational functioning, so that is also another difference with schizophrenia. The symptoms are pretty much the same as schizophrenia. It's just the timeline and not impairing social occupational functioning. Similar demographics, risk factors, etiology, assessment findings to schizophrenia. And usually 1/3 recover completely in 6 months, and the remaining 2/3 go on to develop schizophrenia or schizoaffective disorder. When we talk about schizoaffective, it's a person who has those psychotic symptoms seen in schizophrenia as well as mood disorder symptoms. So they're going to have periods of depression and periods of either like a mania or hypomania. The patient has features of schizophrenia, so the hallucinations, delusions, and disorganizations for more than 2 weeks without prominent mood symptoms. Therefore, it's like not when people are manic with psychotic features. And then they also have periods of mania or depressive features, which is present most of the time, but not when they are psychotic. Less than 1% of the population has this. It's equal in men and women. Men with this disorder tend to have more antisocial behaviors, and risk factors is a family history. We have to look at the patient history because we need 2 or more symptoms of schizophrenia during a 1 month period and 1 or more mood disorder symptoms. So a depression or mania or mixed episode. There's 2 subtypes. So you'll see this often written schizoaffective depressed type. And that's when their prominent symptom is when they're in a depressive episode. And then their schizoaffective bipolar type when the prominent mood is when they are in a manic or mixed state. Physical exam findings, lab findings, mental status exam findings are all similar to schizophrenia. And treatment may also include pharmacology or non-pharmacological interventions similar to bipolar or major depressive disorder. Then we have delusional disorder. This is the presence of 1 or more non-bizarre delusion for at least a month. Psychosocial functioning or daily behavior does not impact except as they surround the delusion. They usually do not have other symptoms. Rare cases have hallucinations and mood disturbances. Men are more likely to have paranoid delusions. Women are more likely to have erotomania. And risk factors include those with the disorder of the limbic system or basal ganglia. So we went over this at the beginning, but just to bring them back up on the screen, different types of delusions. So we have the persecutory, the grandiose, the jealous, the somatic, the erratomatic, and the mixed. Then there is a shared psychotic disorder, also known as folie-à-deux. This is the development of a delusion in a client who has a close relationship with another person who believes the same delusion. A person who already has the delusion, usually has schizophrenia, is the dominant person in the relationship, and this person gradually imposes their delusion on the other person. The person is usually in a long-term close relationship. Treatment is similar to schizophrenia, and it has a poor prognosis if the person remains in the relationship. Better prognosis if they separate from that person. Sorry, 1 second. All right, now we're going to talk about catatonia. Catatonia is one of my favorite conditions to treat because you can really see a difference in people and you can really help people. And it's just very interesting. And it's also kind of hard to detect sometimes, which makes it kind of exciting when you find it. So, what is catatonia? So it's a clinical syndrome of marked psychomotor disturbances. So there can be decreased motor activity, decreased engagement during the interview, excessive or particular motor activity. It depends on the type, but we are going to go over the different types. But really, the main thing is it's a secondary response to an underlying illness that requires quick diagnosis and treatment. So I'd like to think of catatonia like a fever. The fever, right, you can have an infection in your body and then you get a fever, and we need to treat the fever as a separate thing than the infection. Like we want to give Tylenol for a fever and we want to give an antibiotic for the infection. So it's kind of like that. Catatonia needs to be treated separately. We're going to go over the treatment for it. most common is Ativan and very high doses of Ativan. So you have to do that, treat that. Once that has cleared, then you can treat the underlying mental illness that is going on. All right, so different causes. So it can be caused by structural brain disease, which epilepsy, toxic metabolic or infectious disease, a systemic disorder involving the brain, a psychiatric disorder like schizophrenia, affective psychosis, severe anxious states, and emotional shock. It can co-occur. It co-occurs most often with mood disorders. So it can happen with depression. It can happen with bipolar. And 35% of patients with schizophrenia will show signs of catatonia at some point. So 20% of catatonic patients are due to a medical cause rather than psychiatric. However, I will be honest, when I see this, it's typically caused by a psychiatric because people are medically cleared before they come to us, but just kind of interesting. 29% are due to an autoimmune, and this stands for NMDA. Encephalitis is one. Most common in adults. It's the cause of autoimmune catatonia, lupus, encephalitis, viral encephalitis, cyclosporin treatment, epilepsy. So all of these different things. And it can also be substance induced. So you can also see in this chart up here, there's a lot of different medications that will cause catatonia or medical and neurological causes. So there's a lot of different causes. Some of them are like, oh my gosh, for example, like I didn't know a wasp sting, like a wasp sting can cause catatonia. Wow, interesting. Okay. So don't get all caught up in memorizing all of these things. I just thought it was kind of interesting and to know. All right. So clinical features of catatonia. So it depends on the phase of the illness. It depends the type. It's present in 10% of acutely ill psychiatric patients. It's always secondary to another psychiatric illness, and the primary source should be treated first. For a diagnosis, there must be 3 or more of the following. So motoric inability as evidenced by catalepsy, which is can include a waxy flexibility or stupor, excessive purposeless motor activity that is not influenced by external stimuli, extreme negativism or mutism, but again, depends on the type, which we're going to talk about. They're all not mute. There's one that's quite not, but yes, most commonly they are mute. They have involuntary movements such as posturing, stereotyped behaviors, prominent mannerisms, and prominent grimacing. So that's like grimacing of the face. Echolalia, so repeating the same thing over and over again. And then echopraxia, so doing the same movement over and over again. And then over on the side, you can see the DSM-5 criteria for catatonia. And those are all the things we just mentioned. So features of catatonia. So a lot of these words are not common words. So example, Mitterhaien. I forget how you say it, something like that. It's a German word. This is a type of automatic obedience in which the person can be positioned in any posture without minimal effort, even when they're told to resist, but like in a waxy flexibility, the body part immediately returns to the position. So for example, if we're doing catatonia assessment and you lift someone's arm up and then they will bring it down. So like you'll lift their arm up and you'll say, put your arm down, and they won't, but when you let it go, it will return to where it was originally. So these are just some of the words with examples. If you guys are interested in this, you can read it. I'm not going to read them all to you, but it is very interesting. Again, this is one of my favorite things, so I could talk about this all day, but we're going to keep going. All right, so the mechanisms of catatonia. So there are 3 motor pathways that they think are involved. So these include the primary motor cortex and the thymus and the cerebellum, and the prefrontal cortex, SMA, M1, and parietal cortex. So that's one way. Then there are neuroimmunologic disruptions, and then neurotransmitter alterations, so decreases in GABA, glutamate hyperactivity, and dopamine blocking, which makes sense why Ativan works, because Ativan increases GABA and decreases glutamate. So kind of interesting. So again, don't get all caught up in this, but just kind of interesting. All right, so what's going on in the brain? So catatonia is thought to be due to basoganglia disruption at the thalamocortical traits, including motor circuit, which leads to rigidity, anterior cingulate medial orbofrontal circuit, which leads to achetic mutism, lateral hypothalamic connections, which leads to hyperthermia and dysautonomia, and lateral orbofrontal circuit, which imitates and causes repetitive behaviors. Disruptions lead to an increase in dopamine transmission in brain circuits, and other possible pathophysiology include decreased GABA and increased activity at the NMDA receptor. This suggests that the use of benzodiazepines and amantadine as possible therapies. All right, so early signs. There's going to be increase in speech latency. So the patient responds, but there's an increased length of time for that response. It gradually evolves into partial mutism. We might see echolalia, may start subtly and be having the patient repeat the last words of the examiner. The more severe it gets, the more evolved to them only repeating the examiner's words. Motor activity also follows this course. The patient's movement will initially appear slow and will start evolving into holding unusual postures for a long time. And I'm going to show you guys a picture of this. Eventually, they will become frozen, where they put a piece of, where when they're put in a position by somebody else, they will hold that position. That's called waxy flexibility. Echopraxia may also start subtly and can begin with the patient occasionally mimicking the examiner and eventually become them mirroring that person. Symptoms can wax and wane over an hour. Often there are 40 different signs and symptoms that are associated with catatonia, and they can be summarized into 4 groups. So pure motor signs, so posturing, rigidity, and immobility; disturbance of volition, so negativism, automatic obedience, and ambitendency; inability to suppress complex motor activities such as stereotypies, rituals, and echo phenomena; and autonomic instability such as tachycardia and hyperthermia. So we talked about that there were like different types of catatonia. So a lot of the articles that I've read about it talk about catatonia is like an intense state of fear. They are scared frozen. Just think about that. That just sounds totally awful. So, it's just a nice way to kind of think about it in the sense of like, what is this? What is going on? The subtypes of catatonia include stuporous catatonia. So this is why I like this chart. So with stuporous catatonia, they are going to be hypokinetic, so moving much less, and withdrawn, less like reacting activity, right? They're withdrawn. Then there is a malignant catatonia. So this is where you're going to see that like NMS signs and symptoms, right? So that autonomic instability, abnormal vitals, high blood pressure, and heart rate, decreased oxygen levels, increased creatinine kinase, and white blood cell counts. And then we have an excited catatonia. So this one also looks completely different than what we just talked about. So they are hyperkinetic. They are moving a lot, and they are excited in the sense that they have a lot of energy. To me, this looks like when someone is literally out of their mind. They have a lot of energy. They are not making sense. They are doing dangerous things. That is like the excited catatonia. And then we have a periodic catatonia, which can wax and wane between the stuporous and the excited. So when we talk about the stuporous type, this is when we're seeing those negative symptoms, the mutism, the not moving, the staring. I mean, the staring, that to me is like a telltale sign. If someone is just, and they're not moving and they're staring, think about it. Postures may be mundane, sitting or standing in the same position, or unusual. Example, like head raised above the bed as if it was on a pillow, but there's no pillow there. Or like sometimes people just stand with their arms out like this, and it just doesn't make sense, but that's what they're doing, right? They're less responsive to stimuli. Although speech and spontaneous movements are reduced, this is so important. The patients are aware of their surroundings. So when people are catatonic, they are scared, or the stuporous type, they are scared, stiff. They can't move. but they can see and hear everything going on. In more severe cases, they may not be eating or drinking, and they typically will be unresponsive. All right, so there it is, stuporous catatonia. So that is kind of what it looks like. It's not always this obvious, right? This is like an extreme case. It can be much less obvious, where somebody might just be like repeating the same phrase, but not so like I'm scared, I'm scared, I'm scared, right? And then like moving very slowly, like that would be a stuporous type, but it's a lot harder to pick up. And we're going to talk about why it's so important to pick this up. We'll get to it. All right. So excited type. So this is when the person has excessive purposeless movements of their upper and lower limbs. So they could be like flailing around in a frenzy, combative, agitated. If they continue without intervention, they will literally do this until they physically collapse. And it can cause self-injury and harm to others. And then the periodic type, that is a waxing and waning, lasting 4 to 10 days each, kind of between that stupor and excited. And then we have the malignant type. This is a life-threatening condition. And this is, if untreated, the mortality rate is 75 to 100%. And 80% of the time, it can be effectively treated with benzodiazepines and ECT. Signs we're going to see are tachycardia, tachypnea, muscle rigidity, hypertension, hyperthermia, and autonomic instability. All right. And then when catatonia is seen in pediatrics, it mimics that of adults, but has some differences. Childhood catatonia often presents as excited, aggressive, and hyperactive rather than the stuporous type, and it is more often seen in boys. And then in the elderly, catatonia should be considered in the differential diagnoses for apparent rapidly progressive dementia or failure to thrive. First-line treatments are the same, benzodiazepines and ECT. With people with autism, the prevalence is 12 to 20%. Most often in adolescence, and there can be an overlap of symptoms. Therefore, a diagnosis of catatonia must be include a difference from that person's baseline. So complications, because, well, in the stuporous type, if people aren't moving, they have an increased risk of DVT and pulmonary embolism. They can have malnutrition, infection, muscle contractures, and with the malignant catatonia, the autonomic instability can lead to coma and death. When we evaluate in our diagnoses, it can be tricky to diagnose this because there is an inconsistency between scales. Symptoms happen on a spectrum. We talked about the 3 different types. So there's a variety of ways it can manifest. When it does come to rating scales, one of the better known ones is the Bush-Francis Catatonia Rating Scale. It shows a high reliability. It has 23 items. Each one is scored between 0 and 3. The first 14 are used as a screen, and it requires 2 of the first 14 in the past 24-hour period to diagnose catatonia. So what we're looking for is excitement and withdrawal, immobility, grimacing, staring, withdrawal, stereotypy, which is actions being repeated more than usual, mannerisms, so things being performed in an unusual or bizarre way, mutism, that echolalia, verbigeration, so repeating of words or phrases like a broken record, perseverations, echopraxia, mimicking movement. For example, if the examiner scratches their head, does the patient do the same? Posturing, unusual positioning, catalepsy, if they stay in a new passively induced position, rigidity, that waxy flexibility, Geklehaten, so rigidity that increases as force is applied, a grasp reflex, negativism, ambitendency, so patients stuck in a movement, ask them to shake your hand, then repeat, but put your hand out and then ask them to not shake it. So if you put your hand down, say, don't shake my hand, and then see if they will go to take it. Mitigan, if you ask the patient to hold out their arms and not let them lift it. If they raise them up, then it's mitigan, and autonomic obedience. So another thing that is important is to differentiate catatonia from delirium because they can look very similar. And this kind of gets into why it's so important to be able to identify catatonia because The treatment for catatonia will make delirium and worse. And the treatment for psychotic disorders will make catatonia worse. So we need to know what it is, right? Because we can make things worse for people. So catatonia versus delirium. So in catatonia, we went over all of the things you're going to see, but there is an overlap in symptoms, right? So they both develop in a short period of time. They both have excitement, impulsivity, combativeness, and immobility and stupor. And they both represent a change from the baseline. So it can be tricky. So how can we do this? So delirium is a short-lasting, reversible neuropsychiatric condition which leads to disturbance in psychomotor behavior, disturbances of consciousness, perception, thinking, emotions, and cognitive functioning. There is a hyperactive delirium, a hypoactive delirium, a mixed and without motor symptoms. Delirium is the waxing and waning of attention. It is a brain disturbance characterized by the DSM as requiring a disturbance of consciousness or attention, a change in cognition that develops acutely and tends to fluctuate. These patients have lucid periods followed by periods where they become very disorganized. It is a common medical issue with a high rate in the ICU. And assessment tools for delirium, these patients have trouble with things like the serial threes, counting down from 21 by threes, drawing a clock, and spelling words backwards. So the 4 subtypes, so very similar to catatonia, right? So we have the hyperactive, so has agitation, restlessness, aggressiveness. They might be pulling out their IV lines, throwing things, and seeing visual hallucinations. There's a hypoactive, so motor retardation, apathy, slowing of speech, and patients can appear sedated. There's a mix, which is a mixture of both. And then there is a without motor symptoms, so patients only experience the cognitive symptoms of delirium. This represents a critical breakdown of brain function due to severe metabolic disturbance of some kind. Exposure to anesthesia is a common one, and it's estimated that post-operatively 40% of people experience delirium. So as we can see, catatonia and delirium are very similar. Hypoactive, they have that apathy and slowing speech, which is similar to the negativism and mutism seen in catatonia. And then the hyperactive delirium has overlapping symptoms of the excited catatonia. But it's important to differentiate between catatonia and delirium because a benzodiazepine will help catatonia but will make delirium worse. For the most part, benzodiazepines are contraindicated in delirium except with alcohol withdrawal delirium. So to differentiate catatonia from delirium, providers can use serial threes, drawing a clock, or spelling the word world backwards to differentiate. A catatonic patient may take a long time to do these things, but they will give you an accurate answer, unlike a person with delirium. Another clinical pearl is the difference seen between administering Ativan. So we're going to talk about this in a little bit, but to diagnose catatonia or to support a diagnosis, we do something called an Ativan challenge. This is when you're going to give 2 milligrams of Ativan, and within about 30 minutes, you are going to see a drastic difference, pretty drastic difference in the patient's behavior. If they were catatonic, they're going to be able to have a more normal conversation. They're going to be a little bit quicker in how they talk. So yes, we went over this already. So catatonia treatment, even if minimally responsive, they typically remain aware while catatonic and often describe it as a feeling of being very anxious after. Usually benzos are the first line treatment, unless malignant catatonia is present. Benzodiazepines help relieve the GABA dysfunction. ECT is first line treatment in neuroleptic malignant syndrome, malignant catatonia, or delirious catatonia. ECT is thought to work by increasing the blood flow. Also, delirious catatonia is another name for excited catatonia. So that's what we're talking about there. All right. There's an 80 to 100% response rate, and it takes at least 6 sessions for symptom relief to be seen. And we can see in this chart, principles of treatment of catatonia. So this is what we want to do. We want to prevent aspiration and contractures. We want to maintain nutrition, initiate DVT and pulmonary embolism prophylaxis, monitor for autonomic instability, ensure adequate hydration, restart recently discontinued dopamine agonists, reverse hyperthermia, avoid high potency antipsychotics, treat underlying illnesses, treat pressure ulcers, and early treatment is important. All right, so this is a nice I like algorithms. This is a nice algorithm for catatonia. So, we can look like if catatonia diagnosis with greater than 3 features, if it's unclear, like we think it's catatonia, but we're not 100% sure, we do that lorazepam challenge right here. So catatonia, unclear, lorazepam challenge. And then we can decide like, yes, it is. Here's all the different things that we can do. And I'm not going to read this whole thing out to you, but I love algorithms, and I thought this was a nice one. So this is kind of like all the stuff we just talked about in a nice algorithm. All right. So when we talk about Ativan challenge, we kind of went over this. So we give the 2 milligrams of Ativan IV, and we look for a response within 30 minutes. It can be seconds, but sometimes it can take up to 2 to 3 hours. It's usually dramatic. They call this the Lazarus effect, but sometimes it can be subtle. IV is preferred because it's quick acting, easy to administer, and the effective length of action may be longer. If you can't do if you can't do IV, then you can do IM. If you can't do IM, then you can do sublingual, and then you have to do oral. But that's kind of the progression that it goes. So patients with catatonia are less susceptible to sedative effects. When I tell you we give such high doses to treat catatonia, and they're okay. So it's interesting. A positive response to lorazepam is not specific for catatonia. It could also be a seizure disorder or an alcohol or benzo withdrawal. A negative response to lorazepam does not rule out catatonia because some people need higher doses and more of them. Some people also don't respond to benzos and they might need ECT. All right, so here is that Ativan challenge that we talked about. You give the 2 milligrams. If it's a child, it will be less than 2. We like lorazepam more than benzodiazepines because it has a longer effective length of action, and it has a preference for the GABA A receptors, which are more involved in catatonia than the GABA B. And then after administering, we look for speech latency and if it's improved, if echolalia or echopraxia has improved, and is there an ease of movement improved. So these are kind of the steps in the treatment algorithm. Again, I like algorithms. So step 1, give the lorazepam, can be increased to 12 to 16 a day. I don't know why that is spelled wrong, but it actually goes up way higher than that too. So it's just good to know. If that doesn't work, you can go to ECT. And then maybe you can add in different things. So here are just some other medications you could add if you wanted. All right. So treatment options. Again, these are alternatives to benzos and ECT. So here are just some different ones, but typically we're not using these. We're using benzos or ECT. And then algorithm considerations. So, if catatonia is secondary to schizophrenia, consider moving past benzodiazepines. They might need EC. Catatonia co-occurring with psychosis, so we could consider an antipsychotic at step 3 of the algorithm. So step 3 is after you've done Ativan or ECT, you have to treat the catatonia first. And then just gives you some more ideas of things that you could add to the algorithm. So how does it present in practice? So these were just kind of some fun prototypes that I found. So there is the distant mute. You are mostly going to see this person is disconnected. They're mute, immobile. That's them. The waxy stiff. So inertia. You'll see the waxy flexibility, the rigidity, the broken record. So a lot of perseverations, saying the same thing over and over again, hyperactivity, and then the stubborn grunge. So grouch, so a lot of negativism, repetitive movements, and excitement. So these are just other fun ways to think about what you might see. And all right, that is catatonia and psychotic disorders. So I hope you found that helpful. I will see you next time. Thanks. Bye.